Hi, my name is Clifford Hudis, and I am the CEO of the American Society of Clinical Oncology, as well as the host of the ASCO in Action podcast. About twice a month, I interview thought leaders in healthcare and experts in oncology, and we provide analysis and commentary on a wide range of cancer policy and practice issues. You can find the ASCO in Action podcast on Apple Podcasts or wherever you are listening to this show. And you can find all 9 of ASCO's podcasts, which cover a wide range of educational and scientific content and offer enriching insight into the world of cancer care at podcast.asco.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
Hello and welcome to the ASCO Guidelines podcast series, brought to you by the ASCO Podcast Network, a collection of 9 programs covering a range of educational and scientific content and offering enriching insight into the world of cancer care. You can find all the shows, including this one, at podcasts.asco.org. My name is Brittany Harvey, and today I'm interviewing Dr. Pauline Funjain from Cleveland Clinic, co-chair on Systemic Therapy of Melanoma, ASCO Guideline. Thank you for being here today, Dr. Funjain.
Thank you for the opportunity to share this guideline.
First, can you give us a general overview of what this guideline covers?
Yep, absolutely. So this is ASCO's first guideline on the systemic therapy of melanoma. The guideline covers all the current therapies that an oncologist today would consider in the treatment of melanoma. So that includes immunotherapy, targeted therapy, and injectional therapy. And so as with all the other ASCO guidelines, these recommendations are really based on available high-quality data, which really is comprised of, most importantly, phase 3 randomized data, and then also data from rigorous systematic reviews or meta-analyses. So using this sort of stricter data-driven approach, the ASCO guideline covers treatment recommendations over sort of 4 main categories of melanoma. The first being the neoadjuvant approach to cutaneous melanoma, then the adjuvant approach to cutaneous melanoma, then treatment for unresectable or metastatic cutaneous melanoma, and then lastly, the systemic treatment for non-cutaneous melanomas.
And what are those key recommendations of the 4 categories that you just mentioned for this guideline?
The recommendations are ordered by course of disease in the guideline. So it starts with neoadjuvant, then adjuvant, then metastatic or unresectable, and then separately non-cutaneous melanomas. So let me summarize the recommendations in that order. So starting with the neoadjuvant setting, the committee really acknowledged that there's a lot of promising data in this space, but really that the published data that are available are just too immature to make a firm guideline. So in this situation, the neoadjuvant situation, no recommendation is made for or against the routine use of systemic therapy. In the adjuvant setting, recommendations really depend on stage. So for resected stage 2 disease, again, there are trials that are open, but there are no data available, so no recommendation is made in that setting. For resected stage 3 disease, regardless of BRAF mutation status, nivolumab or pembrolizumab can be offered as adjuvant therapy for the duration of 52 weeks. For BRAF mutant melanomas that are stage 3, targeted therapy with dabrafenib trametinib is also an option for 52 weeks. For resected stage 4, slightly different, data are not available for the use of pembrolizumab or dabrafenib trametinib in adjuvant setting. However, by informal consensus, they may be offered as options. And the important thing to note about the stage 3 and resected stage 4 setting is that BRAF is recommended in all cases where systemic therapy is being considered, but the results don't have to be back by the time of the decision. So this was another informal consensus recommendation. In the metastatic setting, so for first-line treatment of either metastatic or unresectable melanoma, regardless of BRAF mutation status, the combination of ipilimumab and nivolumab, single-agent nivolumab or single-agent pembrolizumab could be offered. One small note for that is that for now, the recommended dosing for the combination of ipilimumab and nivolumab remain the FDA-approved dosing for melanoma, so that's ipilimumab at 3 mg per kg and nivolumab at 1 mg per kg every 4 weeks for 4 cycles. So in the metastatic setting, where there is metastatic or unresectable melanoma that is BRAF mutant, so besides the 3 immunotherapy regimens that we just discussed, the BRAF-MEK inhibitor combinations can also be offered. So those combinations are dabrafenib, trametinib, cobimetinib, vemurafenib, and encorafenib, binimetinib. For the second-line treatment of unresectable or metastatic melanoma, there is no high-quality data that meet ASCO guideline criteria. So a few recommendations in this space were made on informal consensus. So in the post-frontline PD-1 setting, regardless of BRAF status, ipilimumab or an ipilimumab-containing regimen can be offered. For patients who have an injectable lesion, telimagene laheparevec, or otherwise known as TVEC, can be offered. TVEC, of note, is an option for any patient with an injectable lesion who either cannot or would not undergo the other recommended systemic therapies. In the second-line setting, for patients who have a BRAF mutant melanoma and were originally started on BRAF-MEK inhibitors, either the anti-PD-1 inhibitors, ipilimumab, or ipilimumab-containing regimens can be offered. So in the last set of recommendations for non-cutaneous melanomas, the recommendations were made based on the primary. So in the case of uveal melanoma, no recommendation could be made for or against systemic therapy. There's just not enough data in that space. And for uveal melanoma, really clinical trial enrollment is preferred. For mucosal melanoma, high-quality data was not available, but the informal consensus was that mucosal melanoma can be treated with all of the regimens that were recommended for cutaneous melanoma. So all of the recommendations that are made in the guideline for cutaneous melanoma can apply to mucosal melanoma.
Thank you for that comprehensive overview of those recommendations. Why is this guideline so important, and how will it change practice?
So I think this guideline is, as the first guideline for the systemic treatment of melanoma, I think why it's so important is that melanoma is such a rapidly evolving field. It's flipped its entire treatment algorithm within less than 10 years, and the majority of the FDA approvals have really happened over the last 5 years. So for oncologists and care providers who don't routinely see patients with melanoma, it can be really hard to keep up with all the available therapies and the data that do and do not support therapies in this field, especially when we're talking about rare melanomas and when situations where data are really thin, so second-line treatment and later-line treatment. So I think it's really different for practitioners now. I think before all of this, in sort of the old days, almost all melanomas would be referred to academic centers. But now we have these drugs that are being used in all oncology centers, which is great because more patients with melanoma can stay with their local practitioner. But I think it's challenging because, I think some oncologists may go through this guideline and honestly find it just slightly fulfilling in areas where we have a lack of data, so second-line setting, rare melanomas. But I think that the beauty of the guideline is that when the guideline gets to the point where the recommendations are only informal, it's very clear that in those spaces the data are thin, and that's when it's time for a community oncologist to strongly consider referral to an academic center to be seen by a melanoma specialist. And I think the flip side of that is that with all the recommendations for which there are strong recommendations, and oncologists can feel very confident knowing that their decisions are based in strong data and that they're essentially can't go wrong with the recommendations that are made with strong data. And they can feel very confident, even if they haven't seen a lot of patients with melanoma, feel very confident in their decision making.
And finally, how will these guideline recommendations affect patients?
So ultimately, we hope that if we can keep our oncology colleagues well informed and up to date, that's really better care and outcomes for all patients everywhere with melanoma wherever they live. And that's really the point of putting this guideline out.
Great. Thank you for your time today, Dr. Funjain, and for your work on these important and comprehensive guidelines. It sounds like they'll have a real impact in the community oncology setting.
No problem. Thank you for having me.
And thank you to all of our listeners for tuning into the ASCO Guidelines podcast series. To read the full guideline, go to www.asco.org/melanoma-guidelines. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app, available on iTunes or the Google Play Store. If you have enjoyed what you have heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.